Hello, this presentation will cover benign thyroid lesions. I will look to cover benign thyroid pathology, in particular looking at the investigation and management of thyroid lesions based on the available guidelines, and to test your knowledge. I'll also include some examples of questions from an FRCS question bank that I have. So the British Thyroid Association has produced these guidelines in 2014, looking mainly at the management of thyroid cancer. NICE has some guidelines, in particular NICE guidelines 145, but they also talk about lots of the signs that GPs should look out for in the NICE guidelines 12. The Americans have their own guidelines for patients with thyroid nodules and thyroid cancers, published in 2016. So the British Thyroid Association say that thyroid nodules are palpable in 3 to 7% of the population, and if you look closer with high definition ultrasound or autopsy studies, this prevalence goes up to about 70%. Luckily, around 95% of thyroid nodules investigated with ultrasound and FNA are benign. The NICE guidelines in particular stress that thyroid cancer is uncommon in patients with deranged thyroid function tests, and therefore suggest this as a way of GPs deciding which referral pathway the patient should be sent in on. Risk factors for thyroid cancer include NECA radiation in childhood, obesity, goiters, Hashimoto's thyroiditis puts you at risk of lymphoma, having a personal or family history of thyroid adenomas, Cowan syndrome, FAP, as well as familial thyroid cancers. NICE, in a similar vein, list worrying features of thyroid lesions as being compressive symptoms, obviously, as well as voice change, in particular hoarseness, lymphadenopathy, a rapidly expanding but painless thyroid mass, being euthyroid, being a child, and having a family history, men type 2, autoimmune disorders in those patients more than 40. Consequently, mainly aimed at GPs, they say that if you've got a thyroid lesion that's not changing over several years, lesions that are incidentally identified on imaging, these can be managed by GPs in primary care if they have no other worrying features, i.e. it's an adult patient with no history of NECA radiation, no family history of thyroid cancer, no lymphadenopathy, and no voice changes or stridor. Those patients referring a non-urgent referral to an endocrinologist, not a surgeon, include patients with abnormal thyroid function tests, and they note that thyroid cancer is very rare in this group. In particular, patients with a sudden onset of pain in a thyroid lump, they say are likely to have bled into a thyroid cyst and therefore can be relatively reassured and non-urgently referred. Patients requiring an urgent referral along the 2-week wait pathway include those with a voice change, children, lymphadenopathy, or if the rapidly enlarging thyroid mass is painless, as this can occasionally be a rare presentation of anaplastic thyroid cancer or thyroid lymphoma. Obviously, if your patient's got stridor or compressive symptoms, they need to go to hospital the same day. So, moving on to the first of the questions. This 57-year-old man who's had a cabbage in the past presents with 2 months of an enlarging right thyroid lump. You see that you hear that he's hoarse, However, he says that this voice change is long-standing over many years. What is the likely cause of his hoarseness? If you write down your answer. Yep, so C, left recurrent laryngeal nerve palsy is the most likely cause in this gentleman. A few points. His voice has been hoarse for many years. However, the thyroid lump's only been there for 2 months. And it's likely to have been caused during his cabbage surgery. This is pointing you towards the anatomy of the recurrent laryngeal nerve, which obviously on the left-hand side hooks under the aortic arch, and is therefore at risk of damage during cardiothoracic surgery. Obviously on the right, the recurrent laryngeal nerve hooks under the subclavian artery. There's a quick note here of the importance of laryngoscopy in order to document the vocal cord mobility before you embark on any thyroid surgery. So, possible investigations for the thyroid. Ultrasound and FNA is the backbone of surgeons' investigations, and as I stated before, thyroid function tests will often help you as well. Moving on from that, if you're looking at Graves' disease or Hashimoto, some of the autoantibodies, thyroid peroxidase and TSH receptor antibodies in Graves, and thyroglobulin in Hashimoto's. MRI and CT have more limited scope, and they may be helpful if you're planning surgery or if you think the thyroid lesion is fixed. Isotope scanning can be useful in determining hot and cold nodules, and if you know that you've got a cancer or strongly suspected, calcitonin and CEA may be useful tumour markers for monitoring. Ultrasound, if you send your patient off, they'll come back with a report between U1 and U5, U1 being normal, U2 being benign disease, U3 indeterminate, U4 suspicious, and U5 malignant. And there's a variety of different factors that ultrasonographers will look at to determine this. For those patients who have U3 and above lesions or other worrying features, they will typically get an FNA. In the UK, the cytology will be reported as being between Phi 1 and Phi 5, Phi 1 being non-diagnostic, or you've aspirated a cyst, which obviously has no cellular component. Phi 2 being reassuringly benign, reassuringly normal thyroid tissue. Phi 3, this is subdivided into Phi 3A, which is atypical features, but they're not absolutely certain, either suspicious or diagnostic, and Phi 3F. This is denoting there's a follicular neoplasm of some type. However, of course, with an FNA, you're unable to see the architecture of the tissue, so the histopathologist can't differentiate between a adenoma and a carcinoma, follicular origin. 5-4, they're suspicious of malignancy, and 5-5, they're pretty certain it's a malignant nodule. If you look at the American guidelines, they use the Bethesda system, which is similar to the Phi system I've just gone through. Different trusts will use different pathways. It's from the east of England, looking at their kind of management of thyroid nodules. As I say, ultrasound and cytology forms the backbone of this. Phi 1 nodules you'll want to repeat, but give it some time after the first biopsy, as it will now be inflamed from your first FNA. Typically 3 months or so is reasonable. Phi 2, our trust like you to repeat benign ultrasounds just to make absolutely sure. Phi 3 and above need an FNA. And then take it from there depending on what it shows. A note from our trust guidelines that PET positive thyroid nodules are becoming increasingly prevalent as we perform more PET scans for different reasons. And if you do a PET that picks up a thyroid lesion for another purpose, don't ignore it, because up to 30% of these PET positive thyroid lesions have a risk of malignancy, so refer straight away to your local thyroid lump clinic for FNA and ultrasound. Okay, so moving on to more specific pathology, this seems a reasonable way to divide up the different benign pathologies. You can have a goiter, which is simple. If they become hyperthyroid or toxic, there's a few other causes to think about. Obviously, you've got neoplastic processes, both benign and malignant, as well as inflammatory. Starting with a simple goiter. Goiter is formed because of overstimulation of the thyroid gland by thyroid stimulating hormone. The most common reason for this worldwide is iodine deficiency, and there's a variety of other things such as enzyme deficiencies, genetic factors, people eating too much cabbage, kale and rape, which are supposed to be goitrogens. You can see goiters in pregnancy and puberty, and there's rare things such as a microadenoma in the anterior pituitary, which causes inappropriate secretion of TSH. Hyperplastic goiter is what tends to occur first, I think, and it's all lobules become hyperplastic and overactive and uptake iodine uniformly. As time goes on, this hyperplastic goiter turns into a colloid goiter, where some follicles become inactive and full of colloid, and its other follicles remain overactive. Nodular goiters then develop, where active lobules become more vascular and more hyperplastic until they eventually hemorrhage and necrose. These necrotic lobules coalesce together to form the nodules that you see in the nodular goiter. Actually, most goiters are inactive, and it's only the internodular tissue in between them that remains active. However, this is not uniform. Moving on to thyroid lesions that cause hyperthyroidism. The top three, of course, being Graves, toxic multinodular goiter, and toxic adenoma. You'll also see it in the early phase of thyroiditis before it burns itself out. Obviously, if you give someone levothyroxine or other iodine-containing drugs, that can cause hyperthyroidism. I mentioned earlier the rare TSH-secreting pituitary tumours. Then you get onto some slightly strange germ cell tumours in the testicles and the ovaries. You can get thyrotoxicosis factitia, i.e. someone taking levothyroxine either for weight loss or Munchausen syndrome type scenarios. Thyroid cancer that is then metastasized and remains functional can also give you hyperthyroidism. The most widely known of the hyperthyroidisms would be Graves' disease. This gives you a diffuse vascular goiter along with hyperthyroidism in most cases. The hypertrophy and hyperplasia of the thyroid is caused by autoantibodies directed at the TSH receptor sites. You see this typically in younger women, and it's the one that will be associated with eye signs in your Viva or OSCE, and 50% of patients will have some sort of family association with autoimmune endocrine diseases. Moving on to the next question. What is the commonest complication after a total thyroidectomy for Graves' disease? Again, if you could jot down your answers. It is hypocalcemia. So hypocalcemia, when the British Association of Endocrine and Thyroid Surgeons did an audit, was seen in 25% of patients post-thyroidectomy within the first day, and this dropped down to 12%, requiring long-term calcium supplementation. The famous vocal cord palsy occurs in 1 to 2% of cases, or should do if you're a safe surgeon. The scenario where you have to release the stitches on the ward of someone who's got a post-thyroidectomy bleed, because it's compressing their trachea, again is around 1%. Seroma, 1 to 7%, and keloid scar formation will be determined by your racial origin of your patient, which is somewhere between 4.5 and 16%. Moving on to toxic multinodular goiters. Usually in these cases, a simple nodular goiter is present for a long time before the hyperthyroidism kicks in. In many cases, the nodules are inactive, and it's actually the tissue in between the nodules that is overproducing thyroid hormones. Occasionally, there'll be one of the nodules or several of the nodules become autonomous and toxic goiters. You'll see this in elderly or middle-aged, often women, and you don't see the eye signs that you see in Graves' disease. In a similar vein, a single toxic nodule becomes overactive and autonomous from the pituitary and hypothalamic feedback mechanisms. This may be a solitary nodule, or it might be part of a larger toxic goiter. It's not the hypertrophy and hyperplasia seen in the nodule, and not due to the TSH receptor antibodies seen in Graves' disease. If you do someone's bloods, you'll have little to no TSH, and the rest of the thyroid turns itself off. So to investigate these patients who have hyperthyroidism, both the clinical signs or the profile on the blood, TSH is the most sensitive and specific. If you look at the small chart below, that's the thing that changes, whereas in mild and subclinical, the T4 and T3 might be normal. You can have a look at the antithyroid antibodies that I talked about earlier, and you might also want to do a radiotracer uptake scan or an isotope scan. Looking more at the isotope scans, this is what you'll see in the Graves' disease, where there's diffuse uptake of in the scan, and it's diffuse. If you've got a multinodular goiter, you more have a picture of patchy uptake, and this is what you see in a toxic nodule, where a single focal uptake and the rest of the gland is suppressed. Equally, in thyroiditis or factitious thyrotoxicosis or excess iodine intake, those sorts of things, you won't see any uptake in a radioisotope scan. So this is how NICE suggests you treat a patient with hyperthyroidism. There's 3 approaches. Firstly, radioactive iodine. It's great for Graves' disease and toxic multinodular goiters, and you might want to consider it in single nodules. There's a few caveats and contraindications there, in particular if your patient's pregnant, planning to father a child in the next 6 months, they have thyroid eye disease, that's a relative contraindication, and obviously if it's causing compressive symptoms or you suspect thyroid malignancy. You can give them anti-thyroid drugs, in particular carbimazole. You might want to control some of the symptoms with a beta blocker. Anti-thyroid drugs and beta blockers might also be useful whilst they're waiting for surgery or radioactive iodine. The last option given by NICE here is thyroid surgery, either total thyroidectomy or hemithyroidectomy. Most patients will require levothyroxine, particularly obviously after a total thyroidectomy. Moving on to the next question. You've got a 32-year-old lady with Graves' disease, and you've given her radioactive iodine therapy. Which of the following is correct with regards to radioactive iodine therapy? And it's number 5, producing hypothyroidism in the majority of patients treated. And you'll see hypothyroidism in 80% of patients treated with radioactive iodine. As I said before, it's great for Graves or toxic nodular goiters. Not so great in thyroiditis, as this involves the destruction of the thyroid follicles. Therefore, they don't take up iodine anymore, and so they don't concentrate the radioactivity. The Gray's ophthalmology can be exacerbated by radioactive iodine. However, apparently if you give steroids, this mitigates that somewhat. Don't give it to pregnant people, and those breastfeeding do need to stop breastfeeding for 8 weeks afterwards. The next benign pathology you might come across is thyroid cysts. They're usually benign, but up to 10% of them will have some form of solid component, and that can be malignant in nature, so you do have to be aware. Therefore, the FNA should be performed under ultrasound guidance just to make sure there's no solid component. If there is, you should obviously biopsy that. Most of these can be treated with simple ultrasound-guided drainage. Indications for surgery include suspicion of malignancy. If they're bigger than about 4 centimetres, they keep refilling after you've aspirated them. You've got blood-stained aspirate, and you've got the history of head and neck irradiation. Another solitary nodule include a follicular adenoma. Of note, we mentioned this before with the FNA investigations. An adenoma is differentiated from a follicular carcinoma by the fact there's no invasion of the capsular or pericapsular blood vessels. I mentioned before, doing an FNA of these provides no tissue architecture, therefore the histopathologist won't be able to tell you the difference between a follicular adenoma and carcinoma. That's why they give you the 5-3F denotation in their report. Therefore, you've got to do a wide excision of these 5-3 lesions. Once you've excised it and you're sure it's follicular, you don't need to follow them up particularly. So, 32-year-old lady, she's got a 3-week history of a right-sided neck mass. Ultrasound confirms she's got a 5 centimetre cyst, and that's aspirated to dryness. Because it's got no cells in it, it's reported as Phi1. What's the next most appropriate step in her management? And yeah, as I alluded to before, earlier in this talk, you bring her back after 3 to 6 months. Aspirating a cyst won't give your histopathologist any cellular contents, and if you bring her back to clinic after 3 or 6 months and it's disappeared, you don't need to do anything else. However, if it keeps coming back, you might want to consider surgery at that point. Moving on to thyroiditis, there's a variety of different types: de Quervain's, Hashimoto's, Vidal's, suppurative, and as well as postpartum thyroiditis. De Quervain's is a self-limiting, painful, inflammatory thyroiditis. It's caused by viruses and causes granulomatous inflammation under the microscope. They said there's 4 phases of the inflammation. Treatment is largely non-surgical with anti-inflammatories and occasionally steroids. Hashimoto's is an autoimmune thyroiditis where you get an enlarged nodular thyroid associated with thyroglobulin antibodies as well as thyroid peroxidase antibodies. It'll be associated with other autoimmune diseases such as pernicious anemia, Addison's, and vitiligo. And ultimately, once it's burnt itself out, you'll be left with a hypothyroid patient. Again, surgery doesn't have much of a role to play in the management of this. Some say treatment with thyroxine can help to achieve a euthyroid state quicker. However, there's dispute about this in the literature that I read. Vidal's thyroiditis is a fibrotic reaction and can be associated with similar things such as retroperitoneal and mediastinal fibrosis. This fibrotic change may spread out of the glandular capsule, and you get a woody thyroid gland on examination. Treatment, again, steroids, Thyroxine, and tamoxifen can also help, and unless you're causing compression or other localized problems, surgery doesn't have much of a role to play. So, 27-year-old lady comes with 3 months of sweating and palpitations. She's got a goiter, and her thyroid peroxidase level is normal. So what is the most likely diagnosis in this case? It is, of course, Graves' disease. Of note, she's toxic, and she's got a diffuse goiter, i.e. it's not a toxic nodular, toxic solitary nodule. Hashimoto's gives you this picture, but the thyroid peroxidase is completely normal. You could also have a look at her level of thyrotropin receptor antibodies just to confirm this. Thank you very much for listening.